Ladies and gentlemen, first I would like to introduce the respectable members of the panel of this session. This session will be chaired by Dr. Mahbubur Rahman and co-chaired by Professor Dr. Ashfaq Ahmed and Muhammad bin Afsar Jan. The Honorable Chairperson, Dr. Mahbubur Rahman, is a man who has left an indelible mark on the field of education, rehabilitation, and humanitarian services. Among his many achievements, he founded Peshawar's Pioneer Physiotherapy Institute. He initiated the province's inaugural inclusive education program and played a pivotal role in founding the humanitarian organization in Pakistan. Currently, Dr. Mahbubur Rahman is serving as a chair of several esteemed institutions, including Habib Physiotherapy Complex, Habib Medical Institute, Khushhal Bagh Inclusive School, and Habib Foundation. I would like to request you please join the stage. Dr. Mahbubur Rahman, you are requested to please join the stage for chairing this session. We feel respect to have with us the co-chair of this session, Professor Dr. Ashfaq Ahmed. He is currently working as Dean, Faculty of Allied Health Sciences at the University of Lahore. He has done first ever PhD Physical Therapy in Pakistan. He has more than 20 years of academic, clinical, research, and administrative experience. He has published a number of high impact factor articles in well-renowned national and international journals. He has also worked as Chairman, Board of Director, Pakistan Physiotherapy Association, and a member of National Curriculum Review Committee, HEC, Pakistan. Sir, you are invited to please join us on the stage. Next co-chair of this session is Dr. Muhammad bin Afsar Jan. He has extensive 25 years of clinical and academic experience in the field of physical therapy. He has completed his master's in physiotherapy from University of Queensland, Australia. He remained the Director, Principal, Institute of Physical Medicine and Rehabilitation at Khyber Medical University. Currently, he is Dean Allied Health Sciences at Rahman College of Rehabilitation, Rahman Medical Institute. He is also an executive member of Pakistan Physical Therapy Association, the Australian Physiotherapy Association, and a registered physiotherapist in Physiotherapy Board of Australia. Dr. Afsar's unparalleled dedication and enthusiasm for improving the standard of physical therapy in Pakistan are truly exceptional. Thank you so much, sir, for joining us on the stage today. Respected audience, our keynote speaker today include many reputable names. But before we proceed to this session, let me request you please note down queries that you may have for the question answer session, which will be held at the end of this plenary session. Ladies and gentlemen, it's an honor to introduce our first keynote speaker, Dr. Alia El-Ghawairi, an exceptional person whose contribution has significantly enriched the field of academics, research, and rehabilitation. Dr. Alia's impressive academic journey and impactful contribution to the field of physical therapy have gathered international acclaim. She has completed her master's and PhD from University of Pittsburgh, USA. She currently serves as full professor at School of Rehabilitation Sciences, University of Jordan, and adjunct professor at School of Health and Rehabilitation Sciences, University of Pittsburgh, USA. She is a board member at the World Physiotherapy. Dr. Alia has published numerous research articles and has been working in several projects in collaboration with WHO, Humanity and Inclusion. We are pleased to have a person with us whose journey is an example of unwavering dedication, profound expertise, and remarkable leadership. Ladies and gentlemen, please welcome Professor Dr. Alia Al-Ghawairi to give a keynote speech on effect of transcranial direct current stimulation on sleep in athletes.
Good morning, everybody. Thank you so much. I would like to thank Rifa University for their invitation and generosity, especially Dr. Shakil Ar-Rahman and the organizing committee. Thank you so much. So I will talk to you today about sleep. I hope that you slept well yesterday, first of all. The outlines of my speech, I will talk about what is the characteristics of sleep, also what's the importance of sleep so that you sleep well and try to do your best to sleep. What are the consequences of poor quality of sleep, especially in athletes and sports? And what is the role of you, especially physical therapists, in the management of sleep disorders? So I will start also with this verse from Quran. Bismillahir Rahmanir Rahim. Allahu yatawaffa al-anfusa hina mawtiha wallati lam tamut fi manamiha فيمسك التي قضى عليها الموت ويرسل الأخرى إلى أجل مسمى إن في ذلك لآيات لقوم يتفكرون. So we really need to think about sleep that was mentioned in Quran. And here, of course, as a neurological physical therapist, I go back to the brain. And the brain actually exists in three primary states. It's either awake, or sleep in the rapid eye movement, or sleep without rapid eye movement. So it's very important to know all of these three states of the brain. And when we talk about sleep, actually, it has four characteristics. Usually, there is a reduced motor skills or activities, decreased responses to stimulation, and here we're talking about visual and auditory stimulations, stereotypical postures, and this is your role as physical therapist also to help in these postures, and relatively easy reversibility. What are the roles of sleep? It's very important. The functions of sleep are very important for healthy individuals. As humans, actually, we spend approximately 1/3 of our lives in sleeping. So make sure that you sleep well in the third of your life. Also, it's very important for energy renewal. It is good for waste removal out of your brain. Also, it's very important for damage repair. So if you have any injury, even musculoskeletal injury, you need to sleep well in order to get better. Also, it's important for information organization. So for students, since our audience are mainly students, to organize all of this information that you gain from the university, you need to sleep well. Also, learning consolidation. So just before the exam, you need to sleep very well, because all of these learning and memory will be consolidated in your brain so that you can answer your exams. At the level of the brain, actually, sleep is very important for cognitive functions, and at the level of the body, it's very important for appearance, for immunity function, and for metabolic functions. So let's go directly to athletes, okay? Just to get into this topic. So when we talk about sleep in athletes, actually, it was found that sleep disturbances are more common in athletes than other healthy individuals. So the prevalence is between 50 and 78% among elite athletes. So here we're talking about, the elite athletes, and it is more prevalent compared with non-athletic population. And what are the disturbances of sleep that they suffer from? They usually suffer from shorter sleep duration, which is like about 6 hours, longer sleep latency, they need more time to fall into sleep, and lower sleep efficiency, what we call lower quality of sleep. And here, what are the negative effects or impact actually of sleep in everybody, and especially in athletes, that they have? The consequences is impaired brain function that could affect their judgment and decision making. And in athletes and in sports, it's very important to have good judgment, right? Because you need to take a decision with sometimes milliseconds, right? So it's very important to be able to take these decisions in the right way. Also, it's important that if the bad effect of poor quality of sleep is to increase the pro-inflammatory cytokines. And you know that athletes all the time have some injuries, so this will increase the inflammation. Also, poor quality of sleep may impair their immunity system and immunity functions. Also, it impedes muscle recovery and repair from any damage. So again, even musculoskeletal is very important. Okay, thank you. It might also lead to autonomic nervous system imbalance. And finally, it alters pain perception. So they might, if they don't sleep well, they will feel pain more. So it's very important to understand the effect of poor quality of sleep. And here, I'm sure that you will ask yourself, why are athletes are more susceptible or to sleep disorders? Or why quality of sleep is poorer in athletes more than the non-athletic population? And there are many reasons, and they usually categorize them into two categories: sports reasons or factors and non-sports factors. And this is actually usually related to training schedules, to jet lag because they travel a lot, to smartphones and the screens that we use all the time, and the stress and anxiety that they feel and they face actually. So other factors are related to sports, such as high training loads, unfamiliar sleeping environment that they travel to all the time, early morning trainings, long-haul travel, and night competitions. The non-sport factors are related to individual chromatics, sometimes social demands, and even habits may be considered. So what's your role? It's very important here to know what are the roles of physical therapists in sleep disorders in athletes. Well, first of all, you need to assess the sleep all the time with any individual, not only in sports or athletes. So always ask your patient when they come to the physical therapy session, did they sleep well last night? Okay? If they didn't sleep well, they will not be cooperative with you. They will have many problems, okay? Also, you need to refer. Sometimes you cannot deal with these sleep disorders until you refer them to the physician who is responsible. Okay, sorry. So you need to refer them to the physician to treat them or to give them some medications. Okay, it's not synchronized. Sorry about that. Also, you need to provide some management, and we will talk about. Yes, this is it. Thank you. So you need to provide them with a sleep hygiene, and we will talk about it. Positioning during sleep is very important, and it's your role to educate them about the best positions that they can use. Also, the exercise program, because there are many research articles now that say that exercising in the morning or during the day will help them sleep well during the night. So it is physical therapy. Also address any bed mobility issues. So there are many general questions that you can ask your patient about sleep, but also you can use standardized assessment such as the Pittsburgh Sleep Quality Index, the Epworth Sleepiness Scale, and Insomnia Severity Scale. All of these actually questions that you can ask are included into these questionnaires that you can hand out to your patient in the waiting room, for example, to fill out, or you can ask them directly, okay? Also, there are some objective assessments. So polysomnography, or what is called the sleep lab, is the gold standard for any sleep disorders. So if you find that you cannot detect the sleep disorders in your patient, refer him or her to the physician, and they will ask them to go for sleep lab or polysomnography to understand what's specifically the sleep disorders that they have. What about measuring actual sleep? Also, what's our role? We can give them some diaries to write down when they go to sleep, how long does it take from them to stay in bed before they fall asleep, and so on. And now we have the actigraphy, or the watches that monitor us and monitor our sleep, which is really helpful. So this is also another option that monitors the sleep time and the sleep efficiency. Actually, they are activity monitors, but they also assess sleep. So let's go to the management of sleep disorders and talk about sleep hygiene. Thank you. So actually, sleep hygiene is a set of instructions to modify behaviors and sometimes the environment of your sleep area in order to promote your sleep. So there are a set of things that you can tell your patient or even write them in your language on a sheet of paper and give it to your patient in order to modify their environment, their sleep schedule in order to improve their sleep. And this is used for mild sleep disorders or, you know, the minimal problems. Also, you can use, didn't work. Yeah, it didn't work. Thank you. Okay. What about positioning of sleep? Also, there is an evidence that suggests that acute and chronic exercise has moderate. I'm sorry. It's not working. I'm sorry. So regarding positioning, also as physical therapists, we can ask our patients if they have any painful position, for example, during sleeping, and modify it for them. So they can use pillows, they can use any assistive devices to help them sleep well. Regarding, okay. The third management that you can use also for sleep disorders is exercising, okay? And again, there is a plenty of articles that reported that exercising during the day will improve their sleep at night. And now I will talk to you briefly about a study that I'm still conducting, actually. Sorry about that. Okay. So actually, this study was published last year. It's about the effect of transcranial direct current stimulation on sleep disorders in athletes. This was a protocol that we published. The ongoing clinical trial is still, ongoing until the end of this year. So what is transcranial direct current stimulation? Actually, there is a growing evidence that using this electrical stimulation to the brain would help sleep disorders, okay? In general and specifically in athletes. So what we found actually that there is only one study with a low sample size that worked on athletes, and they were actually children, so below 18 years old. So we thought that there is a gap in the literature of using this TDCS with a higher sample size and adults above 18 years old. So that's why we, okay. So the study parameters that we used, actually, we included or recruited elite athletes. They were selected based on the eligibility criteria and randomly allocated into interventional group or control group. The interventional group was the TDCS, using the transcranial direct current stimulation. Each participant received a 20-minute session of bilateral anodal TDCS with an intensity of 1.5 milliampere in a density in density 3 times a week for 2 weeks. So they received 6 sessions, actually. The TDCS current was delivered only for 30 seconds in the control group, just, to feel this stimulation, because it's a sham therapy. This is the outcomes sets actually subjective and objective sleep parameters, and they are so this is the inclusion-exclusion criteria, and these are the measures. So we use the objective actigraph watches for them 1 week before the clinical trial and 1 week after the end of the clinical trial. We also used insomnia severity scale, Epworth sleepiness scale, Pittsburgh sleep quality index, and since the sleep actually affects psychological aspect, we also assessed depression and anxiety and the stress scale, also the quality of life SF12. This is the diagram this is the way that you use the software actually on the computer. As you can see, I hope it works. Okay, well, as you can see, we used the 2 points here in the prefrontal lobe, okay, to stimulate the brain. So 2 only, as you can see here also. Okay, so this is the diagram here. What we did actually that we screened patients. So regarding the athletes, we didn't include any athlete. We included only the athletes who suffer from poor quality of sleep based on Pittsburgh Sleep Quality Index. So whoever had Pittsburgh Sleep Quality Index of more than 5, we included them. So there was a screening test to include them based on Pittsburgh Sleep Quality Index, okay? So we included only athletes who suffer from poor quality of sleep. Here's the preliminary results. Actually, we included until now only 18 elite athletes have been recruited. 12 of them were in the interventional group and 6 in the control group. The age was 21. The males, females, actually they were equal, so 50% males and 50% females. The years of sport practice, actually the mean years was 6 years. And the type of sports that we included are individual sports, boxing, judo, and karate. So what we found actually until now between and within group differences, that there was no significant differences at baseline, which is good, between the control and the interventional group. But until now, there is no significant differences between them, even after treatment and at follow-up, because the sample size is still low. However, activity level actually in the interventional group was better than the control group after treatment using actigraphy monitors. So it's not the sleep indices that got better, the activity level got better, which means that maybe their sleep got a little bit better and encouraged them to do more activity during the day. We don't know, we're still exploring. Also, no significant differences within the control group after treatment or follow-up. So until now, within group, there was no significant differences. But within group differences in the treatment, as you can see, all sleep actually parameters. So Pittsburgh Sleep Quality Index, for example. So as you can see here, for example, Pittsburgh Sleep Quality Index was 5 at baseline, and it became 3. And lower is better. So they are improving, but until now, we're not getting the significance here. Okay? So for example, the ICE also, it was around 15, and now it's 11. So all the parameters, the sleep parameters, and other actually health parameters are improving, but not to a significant level. So we will see if there's a clinical difference instead of significant difference. But we are still recruiting, so we will see. So in conclusion, we can now confirm that athletes have a high incidence of sleep disorders, and there is a high impact of poor quality of sleep on athletes' physical and cognitive skills. Therefore, it is important to explore effective interventions of sleep disorders in this population. And in our study right now, actually, we think that using the TDCS will be really promising. At the end of my presentation, I would like to invite all of you to the World Physiotherapy Congress that will be held in Tokyo, Japan, after 2 years in 2025. Actually, this is an international conference that you can publicize your research there. You can actually also get the knowledge from other research studies that are held all over the world, and you can also connect and network with physical therapists all around the world. So please, from now, try to apply for the abstracts when the abstract is open and attend the conference. Thank you, and sleep well.
Thank you so much, Professor Dr. Alia Al-Gawari, for expertise you have shared with us. Dear audience, it's a great pleasure to introduce our next honorable speaker, Dr. Shane Patman. Dr. Patman holds the position of Associate Professor at National School of Medicine, Health Sciences and Physiotherapy at the University of Northern Australia. Dr. Shane Patman's academic journey began at the University of Sydney and culminated in the completion of MS and PhD at Curtin University, with a remarkable portfolio comprising 92 publications and his valuable contribution in peer reviewing over 500 pre-publication manuscript for 73 prestigious journals, Dr. Patman has earned a distinguished reputation in academia. His expertise is further acknowledged through his participation as an editorial board member of many journals. Ladies and gentlemen, please join us in extending a very warm welcome to the leading figure in the field of physical therapy, Dr. Shane Patman. Change it from here as well and from this as well.
How do I change like this?
Yes, on both.
Where do I push?
This one, this one.
Yeah,
You have to press this
for
one.
the screen?
This one. No, for the screen you have to press this, and for this screen you have to press this.
Thank you for the kind welcome. For those of you who would like to take a copy of the presentation, if you would like to take the QR code at on the screen at the moment, you are welcome to do so. I will put that QR code at the end of the session if you are unable to capture it just now. So you're welcome to have a copy of the slides. I would like to acknowledge the organising committee and particular Professor Dr. Syed for the support in arranging for my visit here to Pakistan. I'm very appreciative of this opportunity to come here yet again for my third visit to your beautiful country. I have nothing to declare in terms of content around this presentation, but I do have to disclose that the hospitality has caused me to have some extra weight that I am going to be taking home from my visit already. For this presentation, I would like to look and reflect on the last few years and look at the road ahead for us in terms of challenges and opportunities, both for clinical practice as well as for our research opportunities. So starting at look at the big picture and look at the overall context in which we are operating our services today, there are some lessons that have occurred from the pandemic that are worth considering in the clinical space. I don't think any of us could have predicted in 2018 what was coming forward for clinical practice. I think we need to learn from that perhaps we need to be more conscious of scanning the environment and being aware that we may be challenged at any moment and to expect the unexpected. We also need to appreciate that we are an important piece in the puzzle of our society and that we have a role to play in providing early, rapid and aggressive intervention as part of a bigger operation to ensure that we are contributing to good healthcare in our public sector. And we need to obviously live by example. We need to show the values, the behaviours and the confidence to inspire our community that the advice we are providing them is worth following. We found from the pandemic there was lots of information sharing and lots of collaboration within countries, between professions, and that was very valuable. We learnt from what happened in Italy, we learnt from what happened in China, we learnt from what happened in America, and each of our countries probably had a better response because of the sharing of information. And we should do more of that, and conferences are a great way to start that. We know that our existing services were challenged, but we know that it was possible to still conduct research during the pandemic. And it was important to gather data, and we need to make sure in future that we leverage our existing relationships, our networks, our facilities, so that we ensure we capture data to share that information and learn from it. We also learnt that things could have been done better, There were many people who had a disproportionate response in their populations, in their communities to the pandemic, and it has highlighted that there is gross injustice and inequity in our societies and in healthcare. And we need to do better as a society, as a community, as a world. And we also knew that people were not always of the right attitude and like to spread misinformation and conspiracy theories and try and undermine what was a logical, evidence-based approach to how to manage the pandemic. And that is unfortunate, but we can learn from that in our future endeavours. At the coalface, where we were working day to day, it certainly had an impact, and we have learnt many things about how we could be doing things better into the future. Certainly infection control behaviours maybe weren't so good, and now we are very confident and behaving differently with our infection control procedures. We learnt that staff availability and mobility was very important. Your musculoskeletal staff working in the outpatient department needed to help on the inpatient wards. You had occupational therapists and other therapists working in different parts of the hospital to what they were used to. We needed to mobilise and use our workforce to the full scope of their abilities, and we learnt from that. We learnt that our facilities were not set up for social distancing and for isolation and for protecting staff and patients and family from each other. And so our design of workplaces, our service provision, the facilities we provide, the way we clean them, the way we service them, all of that will change, and for the better. We have seen an explosion in information technology. Certainly tele-rehabilitation and telehealth, whilst was there before the pandemic, has really come into its own and is now widely used and accepted both by clinicians and our clients. Supply chain issues were a challenge and continue to be so around the world. I think we learned that we cannot depend on single suppliers and single storage facilities. So the way that we provide our equipment to our clients, the way we provide our infection control procedures to our clients, we need to learn to have contingency plans and other options for how we may continue to maintain our equipment, our consumables, and the things that we need to do to provide the best service. We learnt that our staff, occupational health, is key. There were people who worked very, very hard for very, very long hours doing things that were not necessarily in their comfort zone, and they are continuing to do so, and we are starting to see some challenges. We are starting to see burnout, we are starting to see strikes from health professions. Even this week in the US, there's been a whole organisation of staff going on strike for better conditions because they are just having to accept that occupational work, health and safety has changed. Professional identity was certainly challenged. We all did different roles. We helped each other, we supported each other, and we certainly saw the best in what people had to offer. And work will never actually be the same again, and we need to learn from that. And one of the things we need to do better is look after our workforce. We certainly know that education changed. It was a very different experience for our students, transitioning to online learning, having to do a lot more simulation and assessment online, and that is now embedded in standard practice. Although I must admit, students are wishing that they could do more face-to-face, and so we are seeing an evolution to a hybrid model where there is face-to-face supplemented with online learning. But we also learnt that clinical skills development, the opportunity to do practicums and placements was certainly compromised, and we're going to have challenges in the next few years in seeing how our COVID graduates start to assimilate to this new workforce. Yourself as graduates also were challenged. We know that we were unable to continue mandatory professional development activities, the ability to go to conferences, meetings, and so on. Our travel arrangements were all challenged. And so the way that we as a workforce maintained our skills and progressed our knowledge was challenged. And we've seen the rise of online postgraduate learning, micro-credentialing, and different ways of staying upskilled, and that's for the better. And I think the elephant in the room for everybody in education is the rise of artificial intelligence that has come in the last couple of years, and what impact that is going to have to our learning and teaching activities. I'm not going to say too much about research, but there certainly has been a big impact on our research agenda and our research conduct. The way that we take studies, the way that we recruit patients and find them for our research has been challenged by COVID. How we make sure studies can actually continue and be completed, the feasibility. Many studies were not feasible during the COVID period, and that makes us think about how we go about planning future research. We saw information explosion. We have seen so much new information published in the literature around COVID, and so this dissemination of knowledge from the clinical space into the scientific world has happened faster than it ever has in history before, where that knowledge translation, that availability of information has really accelerated. The flip side of that is that there's some predators in the marketplace that have really taken advantage of that. The publish or perish attitude has seen that there's a lot of rubbish out there in the literature, and I know some other speakers are going to touch on that today. But the one favourable thing I think that has come to the research community's attention much more is the need to involve consumers. The people who are benefiting from the research need to be involved in the decision making and conduct of the research and driving. Specialists a priority during the pandemic, and I would suggest that we learnt a few things about ourselves, about our professional supports, about our organisations that advocate for us, because in many instances we were not considered essential as part of the community's needs. You know, if you needed to see a physical therapist and you were under isolation precautions in your community, then you had to miss out on that service, that healthcare. But if you needed to see a doctor, well, that was okay. So there was disparity in our profession's access to the clients that needed us. So I think we need to reflect, how did our bodies go? How did our professional associations go? How did our organisations go in supporting us as professionals practicing our care at the coalface? And some organisations did very well, and some organisations perhaps could lift their game a little bit. To finish off with, I'd like to talk a little bit about the road forward for the consequences of the pandemic for those who are still affected. And there are many in our community who have a condition called long COVID. Many of you are familiar with it. There is a clearly defined beast. It has many, many different opportunities to present itself. There are many symptoms, over 200 of them are reported. But it's a disease that is a bit unknown. We're not quite sure what it is yet. We're still learning about it. And unfortunately, it is invisible. We cannot see it. You could be sitting next to someone right now who has long COVID and you wouldn't know it. It's not an obvious impairment. So it's not seen by others. It's not something that you can prove you have with a test. And it's not something that necessarily is predictable in its behaviour. And therefore, it's very hard to see it, it's very hard to appreciate it, it's very hard to manage it, and it's very hard to fund services to support it. So how do we, as a rehabilitation and allied health sciences profession, manage people with long COVID in our communities? And I think that's one of the challenges in our practice going forward. How does it challenge our existing models of care and our theories and models of thinking? How can we provide services to people who are unable to travel to receive those services, or are having services that are in a fluctuant manner? They don't necessarily need them every week for a period of time. They may need very episodic care. How do we train people? How do we support people with long COVID who maybe can't travel or participate in standard events? And how can we learn from long COVID so that we can manage it better for them and their families, because it is not just an individual disease, it very much impacts on all of the caregivers and loved ones and work colleagues and so on. We certainly know that World Health Organization agrees that rehabilitation is a human right. Everyone should have access to rehabilitation. But how is that being managed from a long COVID point of view? What is safe in terms of rehabilitation for those with long COVID? How can we ensure that we don't do harm to a disease and a condition that we really do not have full, confident knowledge about? So the World Health Organization has helped us in this space. They have gathered some information. They have put out a clinical management protocol and guideline that is alive, it lives, it breathes, it gets updated as new knowledge and information becomes available to us. And it has particular chapters related to assisting us as rehabilitation providers in managing those with long COVID. Sorry, I just catch up. Yeah, so we can use these resources and make sure that we are keeping up to date because, as I said, they are alive documents and they are constantly updated. These most recent versions from the World Health Organization Living Guideline for Rehabilitation actually came out about 8 weeks ago in August. So, and that's the 7th version of the guidelines already. So they are doing a very good job at helping us with resources. But for us at the coalface, treating patients that come before us, there is a lack of consensus in defining long COVID, and we do not have a standard set of diagnostic criteria. We know some symptoms, we might have some tests for COVID, but we don't have a clear diagnostic criteria to say, yes, you have long COVID. They'll have a variety of symptoms from fatigue, exercise intolerance, difficulties concentrating, but these are very fluctuant. Some days they will have no symptoms, and other days they will be incapacitated. So it makes it very hard for us to manage and very hard for them to plan and fit into normal daily life. And when you have lack of control of your symptoms and no predictability in how those symptoms might appear, then this leads to psychological problems. You have some implications for not being able to manage and cope in your day-to-day life. And as employees, as peers, as educators, I think we need to be aware of this because it impacts very much the healthcare practitioners as well. So how are we communicating to our colleagues, to our peers, to our employees about how we can support them? Are we offering them working from home options? Are we offering them adjustments in their workplace expectations, the jobs they have to do, in order so that they can actually return to work in some sort of capacity at all? Are we accepting that they can't do their full job, but we'll let them do something that they can do so they can still feel like they are participating and engaging in meaningful work? Unless you have long COVID yourself, then it's very hard for you to understand the journey the person is going through. You may be able to empathize, but you haven't experienced it for yourself, so you cannot appreciate what it's like for 15% of them to have lost their jobs because of having long COVID and not being able to return to work. 2/3 of people with long COVID report being bullied and not appreciated and questioned when they are at work about whether their condition is real or whether they are faking their symptoms and malingering. And so that is very undermining. And if this is happening to our peers, to our health workers, then of course that's going to be unacceptable because these are the people who put their heart and soul on the line. Many of them got their COVID from work and now they are being discarded and not supported. And I think that's a real challenge for us to make sure that that's not happening in our workplaces. So what are we doing to help people with long COVID integrate back and into our workplaces and into our community? That is a challenge, and I think we are in a situation where this is very new territory. We need to learn from each other, and we need to be flexible. We need to understand that this is not a linear condition, and that we will only discover success by trialing and error in this space. And so to finish, I would challenge us all for our research and for our clinical practice in this post-pandemic world to be nimble, to be brave. We need to, as individuals and as organisations, be willing to accept change. We need to pivot, we need to be responsive, and we need to learn from experiences. We need to take the opportunity to innovate, do things differently, and learn that the ways we used to do things may not always be best. So to do a good job at this, we need to be keeping an eye on what everybody else is doing and what's happening in other parts of the world. So scan the environment, keep in touch with what the important issues are, engage your consumers, find out what their voice is, and help them integrate their voice into service delivery and planning. We need to do better at service provision, being more equitable, and equality and inclusiveness for all of us, and we need to look after each other. And with that, I'm going to say thank you very much, and I look forward to questions later on.
Thank you so much, sir, for inspiring keynote. Dear audience, we are honored to introduce our next keynote speaker, Dr. Carolyn Bowen, a prominent figure in the field of speech and language pathology. Dr. Carolyn Bowen's career spanning an impressive 42 years journey as a clinical speech and language pathologist. Dr. Bowen's wealth of practical experience formed the foundation of her profound insight. Throughout her remarkable journey, she has been a keen promoter for evidence-based practice, making significant contribution to the child speech development and disorder, developmental language disorders, and science of reading and spelling. Ladies and gentlemen, please join us in extending a very warm welcome to the esteemed leader and educator in speech and language pathology, Dr. Carolyn Bowen.
Okay, is it this one? This one? This one? Right. Okay.
You have to press from
Oh, is
for
it?
changing it to the background.
All right. So, right. Hello, everyone. I've come a long way, as you can see, but I'm very pleased to be here and grateful to the organised committee for the wonderful work they've done in organising this event. I come from the Blue Mountains in New South Wales, just outside Sydney, where we have a lot of interesting wildlife and flora, and I'll come back to that possum at the end. A colleague and I wrote a book about pseudoscience in the clinical classroom, and you might ask, why did we want to do that? Well, the reason that we did was because of the proliferation and impact of fake health and lifestyle information, complementary and alternative medicine, and dubious education practices. Also because of the credibility afforded to pseudoscience, because we value ethical EBP, and because we were and are mindful of the opportunity cost. An opportunity cost is the time, effort, energy, emotion, hope, and money that might have been... Oh, sorry, can you do? So I have to do both, right? A child's willingness and capacity to participate in an intervention are finite quantities. Usually a parent's desire to do their best for their child is never-ending. Families choose non-evidence-based approaches because they believe in them, or due to clever marketing spin, they appear to offer more hope. Low or no evidence intervention won't meet a child's intervention needs, but the practitioner might do a better job than we do of addressing parents' emotional needs. The customer might find them more positive, supportive and affirming, more generous with their time, more willing to share plausible sounding advice, and more holistic and natural and less disappointing. Such practitioners may be very ready to tell parents that although they cannot see it, progress is happening, for example, as the brain supposedly quietly rewires. The electrician's theory of neurology, that they must be patient, attend more often, or put in more time, money and effort, effectively blaming the parent for lack of progress. And furthermore, sometimes their approaches will look to parents to be more like the real thing than the real evidence-based thing. So what did we do? We looked across medical, health and education disciplines at a wide range of conditions, disorders and syndromes, and I've listed some of them there. The one we were particularly interested in was hot housing in typical development, and also made-up conditions that don't actually exist. Hot housing involves interventions and coaching for typically developing babies, toddlers and preschoolers aimed at accelerating their development. Some of these interventions start in utero. The made-up conditions included Erlin syndrome, and a treatment for it, one of the treatments for it this is Game Boy disease. This is another made-up condition. You can buy, for quite a lot of United States dollars, glasses frames that beep when your chin goes down when you're playing with your iPhone. We also analysed what we found, and we discovered that the interventions and ideas ranged from laughable and time-wasting through to the blatantly dangerous. Providers used false claims, dire warnings and scare tactics to sell their products, and they were particularly effective at using guilt as a mechanism. So for Game Boy disease, it apparently results in a number of dreadful problems, including obesity, depression, and spinal disc herniation. Another one with the scare tactics is chelation, which is a dangerous treatment for so-called mercury poisoning, which is a spurious cause of autism. Then there was a big move, as you probably know, on vaccine avoidance, and it's advised in the misguided belief that the MMR vaccine causes autism. So what do? We start with one or sometimes two questions. The first question was, does this intervention work? In other words, is it evidence-based? If we couldn't find the evidence, we then could ask a second question, is it theoretically sound? Now, for the second question to work, we had to understand the proposed therapeutic mechanism of the intervention, or how the intervention is supposed to work. We set the evidence bar quite high when we evaluated the evidence, if there was any, associated with the interventions. Rather than asking ourselves, is this evidence-based, we asked a carefully framed question, what is the level of evidence, if any, for this intervention? When the answers came back, it was not all bad news. 50% of them were based on solid theory and were backed by reasonable and often expanding evidence. So we filed them under Keep Up the Good Work. But then, following the same process, we looked closely at the other 50%. 37 had a degree of face validity showing promise, but were not yet supported by sufficient quality evidence, even though many had been widely implemented for a long time. We filed them under Could Try Harder. Oh, sorry. Sorry, I thought it was coming. Right. So these were some of the Could Try Harder interventions. What we also found, more than 170 interventions didn't make it into the Keep Up the Good Work or the Could Try Harder baskets because they were associated with no convincing evidence. We could have doubled that figure without straying from popularly adopted methodologies. There are two main types of non-evidence-based practice: interventions for which the science arguingly conclusively against them is in, and inadequately studied interventions which are currently weakly supported. For an intervention that is in use but which has been inadequately studied, there should be a theoretically sound, biologically plausible explanation for why the intervention might work. Got it. And a reasoned explanation of how it is supposed to work. All right, thank you. A reasoned explanation for how it is supposed to work. Dubious practices often arise from seemingly trustworthy and mainstream sources, and some well-credentialed professionals are involved in delivering and teaching and promoting pseudoscientific interventions. So we asked, why are some professionals taken in? And probably the three biggest ones were the first one listed there: no time to dig deeply into the research evidence, and the last two, poor information literacy and poor research literacy. Facing these barriers, well-intentioned but time-poor clinicians may access online summaries of research studies which may lack authenticity or which may have been written by seemingly authoritative experts with vested but undeclared interests in omitting unfavourable studies, buffing patchy findings, and overstating positive results. There's a definition here of information literacy. It is a set of abilities that enables us to acquire, evaluate, and use all information. Research literacy, on the other hand, is the ability to access, interpret, and critically evaluate primary research literature. Testing. 1, 2, 1, 2. Combined with well-developed critical thinking skills, they facilitate the discovery and evaluation of information, understanding how information is produced and valued, and ethical use of information to create new knowledge. It allows you to determine the extent of the information needed, access needed information effectively and efficiently, evaluate it and its sources, incorporate it selectively into your knowledge base, use it effectively to accomplish a purpose, and understand the economic, legal, and social issues surrounding the use of information and access, and use information ethically and legally. Research literacy allows you to recognize the features of science versus pseudoscience, and this in turn makes it easier for you to identify pseudoscience, notify interested others when you encounter them, and explain your concerns in a professional manner and inform colleagues and clients. I've contrasted here the characteristics of science, where trust relies on the whole body of evidence, unverifiable claims are rejected, closely defined terms are used, peer-reviewed published research prevails, protocols are publicly available, logic is valued and applied, and collegial relationships are usual and valued. Whereas in pseudoscience, trust relies on credulity, unverified claims are accepted, unscientific vague language is used, our research links on websites often lead nowhere, protocols are kept secret or in-house, fallacies and cherry-picking abound, and guarded relationships are usual. Now, remembering the opportunity costs that I spoke of earlier, mindful of the risks, we devised a 7-point safety checklist for parents, for clinicians to share, discuss, and explain. So, first of all, if something seems too good to be true, it probably is. If a website link to research leads to unpublished in-house reports, white papers, blog entries, and magazine articles, and not to peer-reviewed publications, be alert. Avoid being blinded by the bright lights of pseudo-neuroscience. Be aware that many interventions work a little bit for a little time. Use social media carefully. Use Google Scholar to access information from the peer-reviewed literature, and be wary of cure-all claims and interventions that appear to fix everything. In general, look for proximity between the intervention and the disorder. If someone says they're working on a child's spelling, it should look as though they're working on a child's spelling. As an information and research literate professional, consider the source of the information, the authors of the information, the methodology, the replication status, the plausibility of the information. Does anything seem fishy? Proximity, and whether there's any post-publication peer review. When a client or patient asks, what's your take on this scientific therapy, it's probably one of the best ways of approaching it to say, well, you know how I feel about science. Have you looked at it from that angle? Or would you like me to check it out? Or last time I read about it, there didn't seem to be any science in its favor, but I'll find out about it and see if things have changed and let you know one way or the other. Going on at people about evidence-based practice really doesn't seem to work, but the use of the word science very often does. I've put some tips here about communication about vaccination, which you can generalize to other dangerous practices. Communication about vaccination is unlikely to impact the behavior of firm refusers and those facing access barriers, but it can influence very much the 43% of parents who have questions or concerns about vaccines. Aggressive or dismissive language won't work. It will put them off, likely to put them off vaccination. Open, respectful discussion with a trusted individual can encourage hesitant parents towards vaccination. So here are some tips for the dangerous interventions, talking to people about the anti-vax, bleach therapy, chelation, dynamic baby gymnastics, facilitated communication, homeopathic vaccination, and miracle mineral solutions. And there are many more, as I said, 170 that we looked at. So the tips: ask about and listen to people's concerns. Not everyone is driven by the same issues. What worries these parents? Safety, effectiveness, side effects? Is peer pressure a factor? Are they listening to Karen on Facebook? Acknowledge their concerns. No one refuses to vaccinate because they want their child or other children to get sick. Acknowledge that you see where they're coming from, and this helps to establish trust. Provide information to respond to their concerns. Share personal stories. Emotive stories tend to be more impactful than facts. Share your positive experiences with vaccines and discuss your experience with diseases they prevent. Don't pass judgment. Establish yourself as a trusted, non-judgmental person that they can share their concerns and questions with. Lecturing them will not convince them, but it will deter them from raising the issue with you ever again. In less dangerous situations, you might not be able to accurately define all the dangers. Find out what the family feels their child gains from the non-EBP approach. If their answers are unconvincing and the interventions appear to be so much hocus pocus, there's one way to go. Explain that based on current knowledge, the approach will at the very least create a significant opportunity cost. Addressing workplace ethical dilemmas around pseudoscience, verbally or in writing. Argue your position logically, use clear language, have a close understanding of the science involved, and know that real-life ethical dilemmas are rarely textbook cases with a right way and a wrong way. Sometimes resolving an ethical dilemma requires identification of the least worth course of action. Avoid inflicting personal attacks and deflect them if they come your way. Focus on playing the argument and not the person or the profession, and keeping the client's welfare to the forefront always. We must never present or think of ourselves as superior because of our duty to EBP. By authentically embracing it, we take on concurrent commitments to intellectual humility, curiosity, and leadership. Professionals who are dedicated to EBP are flexible thinkers, lifelong learners who value scholarship, and who change their minds and their practice over time in response to new evidence. Professionals who do not commit to and pursue EBP will lean towards maintaining an invariant course, irrespective of how the world around them is changing. I said I'd come back to that possum who frequents our garden. There's an Australian expression, to stir the possum, which means to liven things up, create a disturbance, to raise issues that others wish left dormant. It's the opposite of going with the flow, which is not rocking the boat, and to be relaxed and accept a situation or decision rather than trying to control it.
We are on the same page. Sorry.
Eh?
Look at the back. Look at the back. We are on the same page.
Oh, I thought you were changing it.
Yes, we are changing, but we'll move slow. You can please same page.
So, right, okay. So you want me to use? Yes. Okay. So there are our two books, one that's been published and is, we're working on a second edition, and one that goes into... Are you right? Yeah, okay. One that is expected in 2024. In the final chapter of the 2017 book, we posed a question. When faced with pseudoscience that is negatively impacting our clients, patients, or students, should we, should you, should they, should someone stir the possum? We concluded that sometimes we must stand up and be counted. Sometimes we must stir the possum. So my take-home message for today is to be unafraid to liven things up, to create a disturbance and raise issues that others wish left dormant. When you do, collaborate with colleagues, seek the expert advice of mentors, think carefully about the issues, plan and discuss your course of action, exercise your professionalism, and be courageous and true to yourself. Finally, something interesting to think about. These authors pronounced the EBP triangle flawed by design and put a persuasive case for replacing the triangle with a diamond, which included looking at the same usual three things, but also objective evidence of a client's progress or lack of. Thank you very much. That's all right. I'm driving these stairs.
Thank you so much, ma'am, for sharing your profound knowledge and experience with us. I would like to introduce with equal pleasure our next distinguished keynote speaker, Dr. Hayat Mustafa. With an impressive professional background in the field of physical therapy and movement science, Hayat Mustafa is a senior clinical instructor at Prime Physio UK and kinetic control accredited tutor at Comra Movement Science UK. Today, Dr. Hayat will be sharing her expertise on the topic of motor control testings and retraining for managing lumbar spine pain. Her insight in this critical area would promise to shed light on innovative approach to managing and alleviating the lumbar pain. You have to change with this, and you have to change from there as well. Okay. For this, you have to change, press down button.
Okay. So can we display the PowerPoint now? Okay, Assalamu alaikum everyone. I'm so privileged, and I want to thank Professor Dr. Shakil and Rifa University for giving me the opportunity to represent Prime Physio UK and Comera Movement Sciences in this prestigious conference. Thank you so much. So I was privileged to be one of the tutors and presenters for Prime Physio and Comera Movement Sciences, and in Egypt, in Middle East, in Asia, and in Africa. I also had the opportunity to shadow tens of international tutors, and definitely each one of them had the impact on my way of thinking. Over time, I started to have my own perspectives that is based on keen understanding for different school thoughts and concepts. So Prime Physio is a British-Egyptian association. It was founded 2006 by Dr. Mahmoud Saad, Associate Professor in Sheffield Hallam University. And we are privileged to have 4 registered offices in Egypt, in UK, in Emirates, and in Turkey. And we provide postgraduate educational courses within 16 countries and more than 25 cities. And also we provide more than 1,500 educational events, and we have more 50,000 members. We are proud to have our international partners who affiliate with us to provide a lot of international programs, from McKinsey, Maitland Institute, Canada Control, IBETA, Business Rehab Clinics, and the Orthopedic Manual Therapy, and the Dynamic Taping Institute. So let's go straight forward to our main topic. So the main problem is low back pain, and low back pain has the highest prevalence globally among the musculoskeletal conditions, and it's the #1 leading cause of disability worldwide. In 2020, 619 million people suffered from lower back pain globally, and by 2050, 843 million people are projected to fall into this category, with prediction that 36.4% rise in low back pain cases, with the highest increase in Asia and Africa. It is estimated that up to 84% of adults have low back pain at a lifetime, and half of them are still report pain and disability 1 year later. So some surgical and pharmaceutical intervention have limited role, but are frequently used. Unfortunately, in USA, in Netherlands, and Australia, and same also for Egypt, surgery and medication have been used, but after the failure of any conservative treatment, but unfortunately with a higher cost and with a lot of complications. And we all know from the guidelines that misusing and overusing of opioids, which is commonly used in this acute attacks of low back pain, has its own side effects. So unfortunately, most of the conservative treatments show small, moderate effect with minimal long-term gains for most of the lower back pain patients. So we definitely need new interventions to manage the problem with low long-term solution. And we all know that we have clear understanding that the movement system that compromising the coordinating interaction of the articular, myofascial tissues, the neural and connective tissue system, along with a variety of biopsychosocial influences, and how all these components could be risk factors for the incidence of low back pain. So the only intervention that appear capable to offer long-term improvement is the exercise. And stated by the APTA 2013, movement is everywhere in life and is critical to personal ability to participate in society. So in this paper, Deborah Falla and Paul Hodges, they looked for the complexity of movement. People with and without pain, they have variety in movement. They have a lot of individual variability in the movement. So there's a lot of individuality, there's a lot of variability, which means that one size can't fit all approach when we treat the low back pain patient. So we need to apply an individual assessment to find what the problem, and then how to find the proper exercises that could be fitted to the patient to obtain a better results. So for us and for a physiotherapist, for all the physiotherapists, movement is a key for optimal life. and for better quality of life. And we need to address the kinesiophysiological condition to follow the symptoms of the patient, to follow the symptom behavior and individualize our assessment and treatment. And this is why we need to explore and how to manage movement impairments that can direct us to optimize the movement and to optimize the function. So, changes on how people coordinate movement have been identified in people with pain, history of pain, fatigue, and link it to the risk of injury. So, in the presence of pain or a history of injury, the many movement strategies available to the individual are no longer present. So individual may employ some backup strategies that are become now their primary options. So the lesser choices they have, they reduce their state of the movement health. So this is why if we looked at our movement, we're going to see that movement impairments come from restriction, or what we call the relative stiffness. And relative stiffness in one of the regions might cause a compensatory or adaptive compensation that might let the patient go in a state of lost movement choices. And what could be a consequences of a lost movement choices? It could be the incidence or the presence of pathology. And whenever we find the pathology, we have symptoms and pain. So our rule is try to break down the cycle and try to find something that could help patients to move properly. So to understand how the patients move properly, we need to understand the movement patterns. So movement patterns is an interaction between the task, the individual, and the environment. The task that represent the activity performed by the person, like swimming, walking, sitting, running, any other activity. The individual that represent the gender, the age, the activity, the psychological or the biopsychosocial model for this patient, any fear of avoidance, any previous beliefs, history of injury, history of pain or fatigue. And also the environment that surround that person, like the society, like the school, like the work environment. All of these are coordinating or interacting together to give us a movement pattern. So if we're going to use the bending forward as one of the examples of the movement impairment, which is very common in low back pain, on performing a task that the central nervous system, the CNS, has to manage the number of degree of freedom of the neuromuscular system. So the central nervous system is thought to manage this complexity of movement by using sets of muscle groups known as the muscle synergies. And the patterning of muscles can help distribute mechanical stress in all the tissues. So during the pain, we can see a lot of movement changes and reducing in the variability for each patient. And to understand the synergies, we need to know that we have 3 classifications to understand the synergy or how the muscle synergies work, which means that we need to understand that we need to test the efficiency of the local stabilizers that works as an anticipatory activation, and also they prevent the excessive local translation in the joint. Also, we need to test the efficiency of the global stabilizers that are responsible for the deceleration and control rotational movement, and also the global mobilizers that are responsible for the load, for the speed, for the change of direction. This means we need the extensibility of the global mobilizers. So it is a cycle of, if I lost the efficiency of my stabilizers, on the other hand, I'm going to lose extensibility or dominancy of my mobilizers, which means for some region, I'm going to find a loss of range of movement. And the cycle will keep moving like that until I break the cycle to get back the efficiency of the group of stabilizers and find again the extensibility of the mobilizers to regain the lost range of movement and give the patient more options to move. This means that I need to apply the cognitive motor control testing to find the site and direction of the lost movement direction, and to test the efficiency of the muscle synergies. And because it's a multidimensional problem, we need to use all our tools in assessing our patient. So we usually use the big 5 components of the assessment, which depends on the active and passive range of movement testing, the neural tension test, and the repeated movement testing to confirm the mechanical nature of the symptoms. And then we will end with the cognitive motor control testing, that it's not about just reducing the symptoms, but we also need to find a long-term improvement that prevent recurrences of the problem. And this is how we use our management plan to understand the site and direction of the lost movement choices and find what are actually happening with the lost range of movement, the control of translation, the control of range, the extensibility or any articular restriction that affects the movement choices. So cognitive motor control assessment evaluates the individual availability to cognitively coordinate movement as a specific joint or region in a particular plane or a specific range of movement and direction of movement. So we use different testing strategies to test the control of the site of pain in the direction of aggravation of pain. And we have the privilege that we can use are the videos available to work, please? Or the videos cannot work? Okay, so thank you so much. So as we see, we have different positions of testing the control. And testing control means if I have a problem in my lumbar spine, this means that I have a site of pain. If the direction of aggravation is the flexion, as an example, this means I have a site and direction. So how to test the motor control or the control of movement? I need to teach the patient how to control the lumbar spine and try to move an adjacent region, which could be thoracic spine or it could be hip, to give the patient more variety to move. So we can use either the standing position or we can use the supine and add some help with the pressure biofeedback stabilizer units, or we can use the quadruped, and all this variability in positions, it also depends on the symptom behavior and the patient's regular functions. So we need a test that guide us to a treatment. So this is why we are going to take from the positions of the testing, how we are going to fit some exercises to retrain our patients. And movement control exercises, which is tailored to the patient needs and function and daily living, show to be more effective in improving disability compared to other interventions. So if we need to apply some motor control retraining, we need to make it tailored. We need to give the patient a good understanding of the movement-related disorders. So in this situation, we will help to unload the pathology, we will help to control the symptoms, and we can help to make some changes in the underlying mechanisms in the pain. So if you look at this study, with respect to especially the global stabilizer and mobilizer synergies, there are some central changes that present, as we can see in those figures, that there are observable changes in the location or displacement in the motor unit representation of synergies in the homunculus as referred to motor smudging. So as we can see, the difference between the two diagrams before and after motor control retraining, we induce a lot of retraining and cognitive feedback to the brain to understand one more time the exact rule for exact muscle classification. So what we can see here is we can have a lot of options or a lot of exercise prescription that will help the patient to retrain the lost movement choices. And we are gonna let the movement occur in a very in the controlled range. So if we did the test and the patient failed at a certain point, I'm trying to let the video work. Okay, I can leave the videos for the organizers if it's not working now. Okay, here it works. So all what we need to do is let the movement occurs only in the ranges that can be controlled by the patient, so we can give a better cognitive awareness for our patient. In this case, we let the patient prioritize the quality of the movement. We want to make it slow. Okay, we want to make it slow. We want to make it with low effort repetition. We need to make it with no provocation of the symptoms. We need to make sure that there is no mobilizer dominancy, especially, for example, the erector spinae, the tensor fasciae lata, the tensor erectus abdominis, superficial glutes, and the hamstrings as well. So our dose will be focus on giving the patient the exercises twice per day for 1 or 2 minutes each. And we need to let the patient do the exercises for up to from 8 to 12 weeks according to the evidence that's growing in the field of the motor control. So our take-home message is always movement matters. We always need long-term solutions for our patient, and exercise outcomes can be optimized when it matches the neuromuscular impairment of each individual and match the patient needs. And cognitive motor control tests identify the movement impairments and help us target long-term improvement and prevention of recurrency. Thank you.
Thank you so much, ma'am, for your insightful keynote. Moving onward to our next keynote speaker, Dr. Aisha Kamal Butt. She holds the decades of clinical and academic experience in the field of speech and language pathology and is a luminary in her field. She holds the prestigious title of Honorary Fellow at Royal College of Speech and Language Pathology. She is currently serves as the Departmental Lead for Internationalization and Senior Lecturer at Manchester Metropolitan University. Dr. Aisha remained the part of RIFA International University for 11 years, where she served as a Professor, Associate Dean in the field of Speech and Language Pathology. Ladies and gentlemen, please join us in extending a very warm and enthusiastic welcome to Dr. Aisha Kamal Butt. I'm wait करेंगे मैं एक copy कर लूँगी.
Bismillah ar-Rahman ar-Rahim. Honorable guests, international speakers, national speakers, faculty, students, friends, ladies and gentlemen, Assalamu alaikum. The amount of sentences and words I've used right now, I'm going to try and reduce all of that. The most unfair thing that has happened is that I am standing here right before lunch again, and somehow this happens on every conference. So my apologies. I will try and do this as quick as I can so that you can go back to your lunch. Or actually you can start lunch. Is it possible for you to just tell me how many of you are speech and language therapists with a show of hand? Oh, congratulations. For once we've got lots of speech therapists. And physios? Right, okay. No, congratulations on having so many physiotherapists as well. I will try and make sure that I speak in a way that helps most people understand what I'm talking about. As somebody who works in the field of speech and language therapy, augmentative and alternative communication is something that is very, very dear to me. Some of you may know what augmentative alternative communication is. Some of you may not. And I'll try and see if I can explain that better. So the two people that I'm very thankful to, who've helped me and supported me in this journey, are Janice Murray and Katie Latham. They've both been very kind. Janice has actually supported me and mentored me through this project. The project where we've worked on breaking barriers is actually bringing AAC, or augmentative alternative communication, to Pakistan. And that's what we've done. The other three people that I must mention here are Julie Lakovich, who is Deputy Head of Speech and Language Therapy at Manchester Met, Julie Marshall, who is my mentor, and Liz Guy, who's actually helped with this whole project. This project was part of a grant that was given to us, which was called the Impact Factor Grant, and therefore the aim of this project was to actually get some impact, and we wanted it to be very outcome-based. So what is augmentative alternative communication? Again, for those people who don't know what it is, it's anything along a continuum on one side where you may be using gestures to be able to communicate, all the way up to very, very high-tech devices. Looking at this, we assume and we think that AAC would be something very, very high-tech. पहली चीज़ जो दिमाग में आती है वो ये आती है कि यार अगर AAC है तो वो definitely कोई machine होगी, कोई object होगा. But AAC is actually just anything as less as gestures. So now that I'm speaking to you here, I asked you a question right in the beginning, and I said, how many of you are speech therapists and physios? And you raised your hand. The fact that you raised your hand is also a means of telling me and communicating with me. And we would count that as AAC as well. I stand here speaking to you, but we've got media in the background. Multimedia is also considered AAC. So anything that augments our understanding, anything that provides us with an opportunity to express ourselves better, is actually called AAC. Alternative is when you find an alternative method. So something along the lines of a device or a voice output device, as you must have seen. It's not working. Or something that you may have seen with Stephen Hawking. So जब Stephen Hawking बोल नहीं सकते थे, तो there was a device that was being used, and that device is called a voice output device. In order to work on the Breaking Barriers platform that we were working on, we contacted the Special Education Department. The Special Education Department was very, very kind, and this is the first time that I think we've ever heard the term being kind in the government sector. Generally, the idea is that they're very unapproachable. But we were very impressed with the fact that there was only one phone call that was needed. Ek phone kiya, and they were available for us. I'm not going to go into the geography of Pakistan. You probably know this very well. But the most important thing is anyone who's working in Pakistan knows how difficult it is. Kitna mushkil hai to work collaboratively, collectively, because culture plays such a huge difference. The culture in the north is very different to the culture in the south, and the culture in itself impacts the way that we access things as well, especially things like language. Actually, moving this is a nightmare. Right. And when we speak about culture, you've probably seen this yesterday, there's a difference between the two. So you've got the rich who are very rich, or the poor who are poor in Pakistan, unfortunately. This picture was taken, the picture on the right was actually taken, or left for you, was all... So the picture was actually taken on the day that I went for the training. And this picture shows you how some people are actually living below poverty line. The question here is, for somebody who is living in this makeshift house, is AAC even a priority for them? And this is a question that is often asked, कि क्या ज़रूरत है AAC की? AAC क्या करेगा? ये लोग तो खाने पीने के भी, इनके पास तो खाने को नहीं है. The fact is, somebody who's poor does not mean that they don't have the right to the same treatment and the same opportunities. And therefore, it was very important for us to break these barriers. Another problem that we face often, and I'm sure the battery's down for this as well, by the way. Another problem that we face, and I think a lot of people will know here, especially Ilyas Saab, who's sitting in the audience. Another very, very big issue is the finances and the resources that we're dealing with. So our intentions are to work on this. I think I'm going to leave this, and I'll probably be very quick because you're probably waiting for your lunch. आपका computer, laptop नहीं काम कर रहा. So one of the biggest problems that we have in a country where the definition of disability isn't clear, how do you start working on disability? One of the projects that we worked on was a WHO Gates project. Dr. Ilyas, who will be speaking later, he and I actually went to Geneva to present, and that's where I met him and saw some of his wonderful work that he's going to be talking about today. The GATE project is a project that looks at 50 assistive devices. Those devices are not just for speech therapists, they're for physios, for OTs, but they've devised 50 devices, assistive devices, and the aim was to actually provide these devices to children with needs. Within these 50 devices, as you can see, most of them are either physio or OT devices. The only 3 or 4 that you can see are for speech and language therapy. These devices include communication devices such as books or key systems. However, in a report that just came in 2022, if you can find me the communication devices, I will get you a present, I promise. But there are no communication devices. Whether they're paired with hearing impairment, whether they're paired somewhere else, we don't know. But how sad is it that there are 50 devices out of which there are only 4 for speech, and then within that there is no further report to state where those devices are. Whether they've reached the end people, we don't know. Why isn't AAC given the respect that it deserves? Initially because there are certain myths, and these myths exist because we have physiotherapists, OTs, allied health professionals who are working in the field, and also speech and language therapists who don't actually believe in the importance of AAC. So there are myths. There is a gap between the knowledge and the confidence that we have. There are certain attitudes, and obviously there's non-availability of resources. Myths include things like, if I put my child on an AAC device, or if I use pictures for my child to communicate, my child will never be able to communicate. We believe that it will hinder their growth or their ability to speak. We believe that our child will remain non-verbal. And these are mindsets that we need to change. In order to change these mindsets, we worked on this grant where we took 21 speech and language therapists from the remotest parts of Punjab. So 21 speech and language therapists working in the special education department, remotest areas of Punjab, and we actually trained them in AAC. And one of the aims that we were looking at was, what are their attitudes? How can we change their attitude? So what we did was, we did a pre-testing, went in, trained them on AAC, and then did a post-test. But because we know attending a conference or attending a workshop in itself is not sufficient, we asked them to provide us with case studies. So they had 6 months to work with these children, and then they came back and they provided us with case studies. These case studies were actually presented 2 weeks ago, and they were amazing case studies. And that showed us the power of the work that we had done. Just a quick overview on what we were looking at. So we were basically looking at what was their knowledge like, or what was their attitude like before the training, what happened after the training, and what demographic variables played a role. The questionnaire was designed on a 5-part Likert scale. They were very short questions, and we looked at them together. These questions basically came out of previous studies that were published. And these questions, like I said, they were Likert scale. I'm not going to go into them because we don't have enough time at the moment. But the results basically showed actually, this is not working, so I'll just tell you here. 21 therapists were trained with AAC devices. They were trained on assessment and therapy. We went in and said, we'll come back in 6 months' time to see what is the quality of work that you present. They came back to us with case studies that were presented 2 weeks ago. The case studies were phenomenal. They were actually good pieces of work. But one of the things that one of the speech therapists said to me, and it really resonated with me, was she said parents were very reluctant to actually use AAC or pictures with their children. But one of these children had a board, a communication board. And she said what changed for me as a speech and language therapist was that his grandmother had just fallen down. And he ran up to his parents and pointed to help and grandmother. And she said that when the parents came in, the grandmother was actually on the floor. And the impact of what had happened left the parents speechless. And the parents did come back and say they wanted to put this child on an AAC device. And within 6 months, we've seen this child from being non-verbal to using an AAC device through one of these apps fluently. So a child in a remote area through their phone is actually using, through an app, is actually communicating. A child who was unable to do that. The power of technology is tremendous, and I think it's very important for us to embrace that. I will probably finish here. It's a shame that this couldn't, don't worry, I won't start again. But just a quick note right at the end. For some people who have actually made a tremendous contribution to the field of speech and language therapy. So these are some people that I need to thank here today. E.A. Draffin was one of the first people who came to Pakistan, and she came and provided us with a conference platform, and she has since then been with us. So I really do need to acknowledge her work in the field of speech and language therapy in Pakistan, particularly with AAC. Dr. Sikandar Khan, Dr. Sikandar Riaz Khan, who's at the University of Lahore, his publications. मेरी बड़ी धमाकेदार presentation थी, आप गिर गए. Dr. Sikandar Khan has been amazing. He's published a lot of work in the field. Dr. Humaira Shamim Kiani, head of department, she's just had a conference as well as a seminar, and she continues to publish in the field of AAC, continues to help with AAC work, and we are looking at taking this further on. Dr. Iram Nawaz, inshallah, very soon to be. She's doing her PhD in AAC, but she has been teaching in AAC for the last 9 years. So any work that has been done in the field of AAC, good or bad, is due to her. Good maybe because of me, bad because of her. And Amna Imran has developed COCO, which is one of the first assistive devices that is in Urdu in Pakistan. So thank you very much from MMU, all the way here. Jazakallah khair.
Deep gratitude, ma'am. It was truly impactful. Ladies and gentlemen, it's the both honor and privilege to introduce our next distinguished keynote speaker, Dr. Syed Ilyas. Dr. Ilyas is not only an American board-certified physical therapist, but also an exemplary leader in the field of physical rehabilitation. As the Chief Executive Officer of Paraplegic Center, Hayatabad, Peshawar, his visionary leadership has had a profound impact on the healthcare landscape of KPK region. Dear audience, please join me in extending a warm welcome to Dr. Syed Ilyas. Sir, अभी ना अपना इसको पीछे से कर लें. किधर है? किधर है? वो अंदर पड़ा हुआ है. ये ना मैम. यहाँ से करूँगा. इधर से पीछे होगा. अभी ये चल नहीं रहा. अभी ऑन होता है तो.
चलिए. Bismillahirrahmanirrahim. Assalamu alaikum. First of all, I would just like to thank, offer heartiest thanks to Mr. Shakil, Dr. Asghar Khan, Refa International University, all the participants, the sponsors of this humongous, huge program. My presentation is not going to be anything what you already have been through. The only thing which I can do is I will not let you sleep on me, and I will not let you feel so hungry till I'm here on the stand. In a country like Pakistan, with a population of 250 million, all of you know that most of the healthcare system is being controlled by the government in Pakistan, while only a very little percentage of people have access to medical services. Forget about rehab services. I mean essential healthcare services. Not many people can afford what modern medical science offers to them in Pakistan. That's why government is extremely important. If we are unable to integrate rehab medicine into the mainstream medicine, we will never be able to establish anything. Yes, we will be able to have hundreds and thousands of graduates from all these private and government sector universities, but if we don't have jobs for them, if we cannot place them, it will be a disaster. And to overcome that kind of disaster, we have just a minor success in the Khyber Pakhtunkhwa province. We were able to integrate comprehensive physical rehabilitation into modern medicine, and to that extent, since I'm here, it's very late, everybody is tired, so I will just quickly go through my presentation. And there are things which I really would love to elaborate, and I would really love to discuss them in details with you, but unfortunately due to the shortage of time, I'll just quickly go through. I wish I had the freedom to. Can you hear me if I'm here? Okay, then I'll have to stay here. All right. Now, as all of you know, that modern medicine is not just limited to curative medicine. Unfortunately, in Pakistan, most of the budget, actually almost every penny which they keep for the medical budget, the healthcare budget in Pakistan, federal, be it federal or be it provincial, it is only, oh, thank you, that will really help me. Okay, so in Pakistan, most of our budget is being allocated to the curative branch of medicine. And most of us, it's very unfortunate that even the medical fraternity don't realize that modern medicine has 5 components, that modern medicine is based on 5 pillars. Even sometimes people who are being, the rehab professionals sometimes don't even realize that modern medicine has 5 pillars: promotive medicine, preventive medicine, curative medicine, rehabilitative, and palliative medicine. In Pakistan, all what you hear, whatever is being practiced in Pakistan is medicine and surgery, which is the curative branch. So, oh, I put it in my pocket, man. All right. Okay. Now, I will just skip a lot of these slides and go to the components of rehab medicine. The components of rehab medicine which I have mentioned here, they may not be acceptable to some of the organization, and or maybe in some countries Some of these branches are not being considered as branches or components of rehab medicine. But when it comes to Pakistan, it's a country, it's a vast country, it's a country of huge population. People are living in mountains, in far-flung areas, in deserts. For them, it's really not possible, for people with disability especially, to be able to avail all those services. That's why I have included few of the things which you probably may not want to include, but when it comes to the context of Pakistan, I have included all these: medical management, surgical intervention, nursing care, physiotherapy, occupational therapy, and name it. It even includes recreational therapy, wheelchair service, and all these other services which are mentioned right here. Okay, come on. All right. Now, the concept of comprehensive physical rehabilitation, what I have came to know with the experience of last 20 years, it has to be holistic. Whatever person with disability or whoever needs rehabilitation services, whatever services they need, all those services must be available under one roof, and all the professionals working for that purpose should know each other. Even in this audience, if I ask that, is there any P&O here, a prosthetist and orthotist here? I don't think there is anyone. There may not be a lot of occupational therapists here, and there may not be any recreational therapist here. I may not, you may not show, no one may raise a hand if I say, is there any wheelchair professional here? I don't think so. So what kind of comprehensive rehabilitation it is? To that extent, we have developed a model, and I'm going to show that model, which it's not an academic or a clinical type of presentation. Bear with me if you don't like it, but that's what it is. At Paraplegic Center Peshawar, I'll just skip that, we have two different teams, and this is a model which is really effective in Pakistan. In Pakistan, if you do it this way, it will definitely meet success. Medical doctors, physiotherapists, occupational therapists, speech-language pathologists, audiologists, optometrists, orthotists, pharmacists, rehab nurses, psychologists, behavior therapists, nutritionists, wheelchair practitioners, social workers, recreational therapists, vocational trainers, and rehab engineers. And whatever you see in this column, all these teams are there in Paraplegic Center. Now when it comes to part-time employees, and you will be surprised that at Paraplegic Center, we don't have any full-time rehab doctor. We don't have any full-time spine and orthopedic surgeon. But we do have, they are available to us. We can call upon them anytime. They can visit Paraplegic Center anytime, and we can consult them. But if we just hire one single orthopedic surgeon, and if one single orthopedic surgeon comes and work at Paraplegic Center, all the budget we have will be allocated to him, and there will be no rehab in Paraplegic Center. And keep in mind that Paraplegic Center is the only facility of its kind from Kabul to Karachi where people with spinal cord injuries are comprehensively rehabilitated. Now, how we do rehabilitate them? Okay. Once again, I will quickly go through the medical management, flap. In Paraplegic Center, this is again really surprising. Wound care has nothing to do with rehabilitation directly. Indirectly, there may be physiotherapists and maybe a lot of other rehab professionals involved when it comes to wound care. But wound care itself is not rehabilitation. But at Paraplegic Center, we have a huge wound care program, and almost half of our budget goes into wound care. Why? Because we receive 93% of our cases, 93% of our patients from Lahore, from Karachi, from Multan, from Kabul, and from Peshawar, and from all over the region. We are receiving them with huge, big pressure sores. We have no choice but to treat them for pressure sores first. And it is very unfortunate, we don't want to do that, but we have to. Now, we have nursing at paraplegic center is equal to nurturing. It starts anywhere from a cool or a warm. Okay, I'm sorry. You know, if I cut it short, it will have no value. So go ahead, raise your hand. You guys want me to finish the presentation, or you want me to cut it short for the food? Please raise your hand. Who want me to continue? Okay, then I'll continue. Thank you. Okay, now nursing care at paraplegic center also includes even a shower, a cold shower after 6 months. Some of our patients have not taken any shower for years. All what they're seeing at their home is just one little fan. That's all. So you can imagine what kind of patients we are dealing with. Now, bedding or positioning every 2 hours is extremely important, and you guys are all professionals, so I'll not go through all the detail. Physiotherapy, what is physiotherapy? I'll not go through that. These are 6 different slides. Every slide has a stage of physiotherapy, so I will once again not explain any of that, but I'll quickly go through the next mat activities. Wheelchair selection, modification and maneuverability. Once again in Pakistan, wheelchair is just a little machine which is imported from China. Mostly in Pakistan, the wheelchairs available are orthopedic wheelchairs. They are not active wheelchairs. They are not wheelchairs which are durable, which are repairable. Those wheelchairs not even repairable. And we are creating jobs in China. We send all these poor people collect all their money and taxes, and we send them to China, and we receive wheelchairs which are orthopedic wheelchairs, which are not active wheelchairs. So you can imagine there is no active wheelchair available anywhere but at paraplegic center, because we have our own factory where we manufacture our own wheelchairs. Now, unfortunately I can't go to all the details. I'll proceed. Advanced wheelchair activities that also include transfers and functional mobility. I mean, you give a wheelchair to someone and you don't show them how to transfer to a wheelchair, how to transfer to a car, if you fell off, how you are going to go back into your wheelchair, and you say that we rehabilitated him. In Pakistan, it's a very common claim. People just distribute wheelchairs for many different reasons, but they don't know what wheelchair is all about, what are the types of wheelchairs, what type of wheelchairs a person will need, what kind of alterations you can do. So nobody knows about these things. We do that at paraplegic center. Aggressive strengthening exercises, ambulation and gait training, all these, different stages. What I want to actually share with you, and this is really important, is that for every 100,000, and this is available, this is nothing new, this is not rocket science, you can just Google it right now and you will find that every 100,000 population anywhere in the world needs 95 physiotherapists, 95 physical therapists are needed for a population of 100,000, but in Pakistan only 2 are available, and that is an exaggerated figure. When I say 2, that is exaggerated actually. In reality, there are areas where not even 1 is available. So what about to talk about 2? In Khyber Pakhtunkhwa, we have registered with PEPTA 847 physiotherapists, but only 250 have jobs. If we don't integrate rehab medicine, and if we don't integrate physiotherapy and all the other medical disciplines, rehab disciplines into the healthcare system of Pakistan, there will be no jobs, and the future is going to be bleak. So please mind that we have to, all of us have to together, not just physiotherapists, all the disciplines, we all have to work really hard towards that goal, that we have to integrate into the rehab, into the healthcare system. If the healthcare system don't accept you, if they don't recognize you as a medical professional, then how you are going to, what kind of difference you are going to make? So, okay, now occupational therapy, once again, I'm not going to go into the details, but occupational therapy in paraplegic center has 3 phases. In acute phase, when we receive people with quadriplegics, 25% of our cases are quadriplegics. They go through all the splinting, positioning, and all kinds of these interventions. And then there is another stage which is called rehab phase. In rehab phase, we evaluate them. We first of all determine whatever they can do, what they can do, and what they will be able to do despite the fact that they are quadriplegics, how a C6, C5 quadriplegic will be able to eat, how they're going to write, how they're going to groom, and how they're going to do all kinds of daily life activities. All those are mainly the work of the job of an occupational therapist at Paraplegic Center. And not only that, we design and manufacture all kinds of assistive devices for our patients. Our occupational therapy department does that, and whatever they need, it is provided 100% free of cost to them. These are the kind of assistive devices you can see. They are all manufactured at Paraplegic Center. It costs us 10 rupees, at the most 100 rupees or 200 rupees. We don't need to buy it from any other country. We don't need to spend any of these dollars which are really in shortage in Pakistan. So we don't need to do that, and you can do that too. Lahore can do that too, Karachi can do that too. Unfortunately, there is no will. That's why I have been talking like this for the last 10 years. Actually, for the last 20 years I have been doing it, but unfortunately nobody is giving a heed. Okay, now occupational therapy versus population, you can Google it yourself. Speech language pathology, these services were recently started in Paraplegic Center because mostly our spinal cord injury patients don't need them. Now since we have started autism and we are working with some stroke patients, we are trying to start pediatric rehab and all these other. That's why we have established our speech language pathology department. Now all those figures are also available. Audiology, why I consider audiology also part and parcel of rehab medicine is because if I receive a person, a CP kid for example, there are families which have 5 or 6 CP kids all together in one family. You can imagine a poor family coming from a mountainous area, driving 200 miles, and then you tell them, okay, for a hearing device, you have to go to Islamabad or you have to go to Karachi. That really don't make any sense. That's why you have to have all these services under one roof available to them. Audiologist, optometrist, now I'll just make it quick. Fasten your belts, I'm going to make it quick, okay? Orthotics and prosthetics, I don't need to talk about it a lot. No orthotist and prosthetist is sitting here. Unfortunately, without orthotist and prosthetist, rehab is actually incomplete. There is no rehab if you don't have a good orthotist or prosthetist available in your team. We have a large team available with us. Okay, and I'll once again skip everything. Wheelchair service, you know, this is coming again. But actually wheelchair is a service. It's not just an equipment which you just buy from the market and give it to someone. WHO has come up with 8 steps. No one even know about those 8 steps, but we follow them meticulously. Even postural supportive devices. If a kid like this comes to your clinic, for example, and you give them a wheelchair, and it's an adult wheelchair. Imagine what kind of wheelchair you are giving to that kid and what kind of benefit it is going to give. You have to give a wheelchair which really empowers them, which they can really enjoy. And you need to support them from different directions. So postural supportive devices as well. Okay, as I said, fasten your belt. Okay, all right. Okay, the wheelchair statistics, I will forget about that. Psychological counseling is extremely important. Without psychological counseling, without the presence of strong psychological department, your rehab is useless. If someone is not ready to accept their disability, it's really useless for them to do anything else. Okay, now, come on, okay? Social worker, without social worker, again, things are incomplete. Okay, skills building, vocational training. We are receiving a lot of people with disabilities and they can't go to schools, they can't have professional jobs. What are you going to do with them? So we even try to teach them with different skills. Now, baby care and cooking and household chores and all these are also part of rehab. Recreational therapy is really a big part of rehab. And you know, I wish I had the time, I could have told you stories which will make you cry. What kind of patient we receive, and what recreational therapy does to them, you will really not believe it. Okay, now, come on, quick. Awareness and advocacy is very important. You know, my today's presentation is actually awareness and advocacy. And unfortunately, awareness and advocacy was your job. You were supposed, this hall all these professionals were supposed to work for awareness and advocacy, but unfortunately, we are living in a country where I have to do it. You guys should have done it. Follow-up program, you have to follow your patients. We do follow all our patients. We even make some home alterations for them. We even install a wheelchair accessible bathroom at their homes. So this is a program which is only limited to Khyber Pakhtunkhwa. The rest of the services for everyone. We even, pave the roads for them and things like that. Wheelchair accessible bathrooms, very rudimentary, but nonetheless they need it. OPD services, clubfoot. We have an excellent clubfoot service. I mean, this is a treatment, this is not rehabilitation, but the clubfoot, Debbie is sitting somewhere. Yeah, hi. And since for the last 1 year, we are working with Miracle Feet USA, and that is really giving, dividends, which are really wonderful. Unfortunately, I don't have time to talk about it. Economical and social empowerment is very important. Look at this guy. Sitting on the ground, unable to do anything, but you just give them a motor rickshaw and he will be able to make his own money, his own sustenance. And you can see all these other examples. We have sports and games for our patients. We have vehicle alterations for them. Anyone who needs a vehicle alteration, we will do it right there at our center. They don't need to go anywhere else. We have many success stories, thousands of them. So in Lahore, we have graduates. If you allow me, tomorrow I can call 100 graduates on wheelchair and they can come and show their wings here. Academic program and the rest. I'll just want to show you that we have a future. It costs whatever we do, it costs our patient this much. So you can imagine that if I can do that in Khyber Pakhtunkhwa, the smallest and the poorest province, you can do that right here in Punjab or anywhere else. Vision, mission, forget about it. But I want to show this. This is a new center which is coming up in Banu, and this is a huge center. It is going to be the second largest comprehensive physical rehabilitation center anywhere in Pakistan, and we are going to have it for all the tribal areas which are just recently merged. This is a new program which is coming up in Peshawar, because our center was 25 beds. Today it is 150 beds, but it is not enough anywhere, so we are going to 300 beds, and that is the new building which is being designed for that. Okay, this is my dream rehab center. If anyone wants to see it and want me to explain, I can later on do that. I'm really thankful to every one of you, and I'm really sorry that I had to take that long, but it was really badly needed. Thank you all.
Thank you so much, sir, for your enlightening keynote address. Your insight have truly inspired us. Let's take to our next keynote speaker. It's an honor to introduce Professor Dr. Naveed Babar, who currently serves as Dean, Faculty of Allied Health Sciences at Superior University, Lahore. Dr. Babar's journey in the field of rehabilitation is marked by exceptional dedication and scholarly achievement. Please join us in extending a warm welcome to Professor Dr. Naveed Babar.
Bismillahirrahmanirrahim. I am grateful to Professor Dr. Shakil Rahman Sahab, Professor Dr. Asghar Khan for inviting me to this spacious conference. I welcome all the international delegates to the city of vitality, Lahore. I am a Dean, Superior University, Dean Faculty of Allied Health Sciences. I will talk in English as well as in Urdu, and I am the only person between you and lunch. So I have to gear up this. I think I have only 5 minutes. So कैसे आगे जाएगा? Yes. I was the first person at Rifa International University to join Rifa College of Rehabilitation Sciences in 2007. And then Asghar Bhai, Shakil Bhai, and we have lot of team. और अल्हम्दुलिल्लाह आज मैं ये देख रहा हूँ कि Rifa University में it's the largest faculty, and I own at Superior University is the largest faculty of Superior University with more than 8,500 student body, with more than 200 faculty members. So myself, I hold the degree of PhD in Rehabilitation Sciences and had the honor to be the first PhD in Rehabilitation Sciences. I think this is enough. I want to express about Rehabilitation Sciences and Allied Health Sciences, their future basically. So I skip many things. You know Allied Health Sciences, you know Rehabilitation Sciences. There are 5 disciplines usually defined under Rehabilitation Sciences. As Dr. Ilyas already mentioned you, who are working under Rehabilitation Sciences. And rest of 28 disciplines, except medicine and nursing, are working with the Allied Health Sciences. So these are the disciplines of Allied and Rehabilitation Sciences. Overall 28 disciplines among Rehabilitation and Allied Health Sciences. So their role varies from assessment, diagnosis, evaluation, treatment to play a central role with the doctors of medicine and doctor of surgeries. Next, career scope you already know. Next. ये बेटा आगे चलेगा? Yes. As I joined Superior University 2 years back, universities are known by their vision, mission. So without industry, without spin-off, it's a new thing. हम करिकुलम यूनिवर्सिटी में कुछ और पढ़ा रहे हैं, लेकिन इंडस्ट्री की रिक्वायरमेंट कुछ और है. तो एकेडेमिया इंडस्ट्री लिंकेजेस आर मिसिंग. हमने ये किया कि हमने 2 स्पिन ऑफ रजिस्टर्ड कराए. एक कम्प्रिहेंसिव रिहेबिलिटेशन सेंटर बनाया सुपीरियर यूनिवर्सिटी में. ये सेल्फ सस्टेन मॉडल है. हमने यूनिवर्सिटी से एक पैसा भी नहीं लिया और इंडस्ट्री ने हमारे साथ कोऑपरेट किया और हमने ये कम्प्रिहेंसिव रिहेबिलिटेशन सेंटर बनाया जिसमें तमाम रिहेबिलिटेशन की सर्विसेज अंडर वन रूफ कर, जिसमें फिजिकल थेरेपी, स्पीच थेरेपी, ऑक्यूपेशनल थेरेपी, ऑडियोलॉजी, इवन न्यूट्रिशन एंड डाइटेशन और ट्रामा साइकोलॉजी, ये सारे हमने अंडर वन रूफ कर दिए. न्यूट्रिशन एंड डाइटेशन के बगैर भी रिहेबिलिटेशन मुमकिन नहीं है. तो देयर आर सम फूड आइटम्स, उसमें ऐसी चीज़ें हैं जिनको आप अगर फिक्स कर देते हैं पेशेंट के साथ तो उससे भी उसकी रिहेबिलिटेशन के प्रोसेस में एक्टिविटी होती है. बसारत, अनदर प्रोजेक्ट, इट्स अ लो विजन रिहेबिलिटेशन. जो लोग लो विजन रिहेबिलिटेशन से जिनको प्रॉब्लम होती है, जिनका लो विजन होता है, उनके लिए हमने पूरा एक सेंटर क्रिएट किया है और इसको अब हम इंशाल्लाह फ्रेंचाइज भी कर रहे हैं और पूरे लाहौर में इसकी नेटवर्क होंगे. दिस इज़ अ इम्पैक्ट. देखिए पाकिस्तान में हम यहाँ काम कर रहे हैं, इतने अलाइड हेल्थ, मैंने बताया 8,500 मेरे पास स्टूडेंट है, 3,000 रिफा के पास होगा, यूनिवर्सिटी ऑफ लाहौर के पास 10,000 होगा. तो इतने लोगों की जॉब प्लेसमेंट कैसे होगी? तो वी हैव इनिशिएटेड गो ग्लोबल. हमने सुपीरियर यूनिवर्सिटी ने एक कैंपस अभी ओपन किया है रासुल खैमा में. तो हम ये कर रहे हैं कि हमने ये किया है कि जो हमारे फाइनल ईयर के स्टूडेंट्स हैं उनको हम 1 साल उनकी इंटर्नशिप जो है वो हम यूएई में कराएंगे. हमारा एक मॉडल है 3U1M, 3 years इन यूनिवर्सिटी एंड 1 year इन इंडस्ट्री और ए मार्केट. तो हमारी मार्केट क्या है? हॉस्पिटल्स हैं, लैब्स हैं और इस तरह की जितनी रिलेटेड चीज़ें हैं, अलाइड हेल्थ साइंसेज की हॉस्पिटल्स हैं, क्लिनिक्स हैं, तो उनके साथ मिलके हम काम करेंगे। तो यहाँ पे ये और बाहर हम उनको 1 साल वहाँ पे पढ़ाएंगे। तो गो ग्लोबल का एक हमने इनिशिएटिव लिया है और इसके साथ ये रासुल खैमा में हम इसको शुरू करने जा रहे हैं। दिस इज़ वन ऑफ द इम्पैक्ट। हमने एक रेस्कॉन इसी तरह की बहुत अच्छी कॉन्फ्रेंस हमने कराई पिछले साल, उसका ये एक हल्का सा इम्पैक्ट है कि जिसमें 6000 के करीब डेलीगेट्स थे और उसमें इंटरनेशनल 20 के करीब स्पीकर्स थे, नेशनल। फिर इसमें से इसका हमने इम्पैक्ट क्या निकाला। ये कॉन्फ्रेंस हो रही है तो मैं अभी डिस्कशन कर रहा था कि हमें इसका इम्पैक्ट कैलकुलेट करना चाहिए। ऑफिस ऑफ रिसर्च इनोवेशन एंड कमर्शलाइजेशन, जो भी यूनिवर्सिटीज़ में काम करते हैं, मैं क्योंकि एक एकेडमिशियन हूँ तो मैं यूनिवर्सिटी से रिलेटेड ज़रा ज़्यादा बात करूँगा। तो जितने हमारे ऑरिक के डिपार्टमेंट हैं उनको चाहिए कि इसका इम्पैक्ट कैलकुलेट करें। कितने वाइट पेपर यहाँ से निकले आज, कितने बुक चैप्टर्स निकले इन एब्स्ट्रैक्ट्स में से, ये जितनी स्पीच हुई है, जितने कीनोट स्पीकर्स थे नेशनल इंटरनेशनल, क्या प्रोडक्ट लॉन्च हो सकती है इससे, क्या कमर्शियल एक्टिविटी हो सकती है यहाँ से। तो इसको कैलकुलेट करें और उसको आगे कमर्शलाइज करें। हम बहुत ज़्यादा पीछे हैं अलाइड और रिहेबिलिटेशन के लोग। हम रेगुलर रिसर्च पे फोकस करते हैं और रेगुलर चीज़ों पे जा रहे होते हैं। हमारा इंडस्ट्री का सलूशन है। मैंने अलाइड हेल्थ साइंसेज में एक नारा लगाया हुआ है, 1 PhD फैकल्टी मेंबर 1 इंडस्ट्री सलूशन। जिसको भी PhD वाले को मैंने अपने यहाँ रखा है उसको मैंने कहा कि तुमने PhD की हुई है, एक इंडस्ट्री का मुझे सोल्यूशन ला के दो कि इंडस्ट्री को क्या हम सोल्यूशन दे सकते हैं। तो हमें भी सारा उसी पे फोकस करना पड़ेगा। और 2024 में हम इसी हॉल में इंशाल्लाह एक करवा रहे हैं कॉन्फ्रेंस, रेस्कॉन 2nd, तो इंशाल्लाह वहाँ पे भी आपसे मुलाकात होगी। एक मैंने और हमने डिफ्रेंशिएट किया क्योंकि हर यहाँ पे सारे एरिया के लोग मुझे मिले हैं, ऑप्टोमेट्री से मिले हैं, रेडियोलॉजी से मिले हैं, फिजिकल थेरेपी से, स्पीच थेरेपी के हर तरह के लोग अवेलेबल हैं, मिले। तो हमें डिपार्टमेंट्स को भी स्ट्रेंथन करना चाहिए। मेरे यहाँ 10 डिपार्टमेंट हैं, तो मैंने 10 डिपार्टमेंट को अलग-अलग टास्क में कन्वर्ट कर दिया कि ऑप्टोमेट्री वाले ऑप्टो कौन कराएं, वो अपने लोगों को, अपने स्पेशलिस्ट लोगों को बुलाएं, वहाँ पे करिकुलम की बात हो, वहाँ पे उनके क्लिनिकल प्रैक्टिसेस की बात हो, ताकि वो इंडस्ट्री में जाके अपना काम कर सकें। और इंडस्ट्री वालों को यहाँ पे बुलाएं, उनके टॉक शोज़ हों, ताकि कोई वे आउट, वे फॉरवर्ड निकल सके कि हम क्या कंट्रीब्यूट कर सकते हैं। इसी तरीके से हर फील्ड में ऑप्टो कौन है, न्यूट्रा कौन है, स्पीक कौन है, स्पोर्ट्स के लोग जो हैं वो करवा रहे हैं अपनी, इसी तरह मेडिकल इमेजिंग वाले करवा रहे हैं, MT मेडिकल टेक्नोलॉजी वाले अपनी कॉन्फ्रेंस करा रहे हैं। इवन हमने पैरामेडिक्स को भी नहीं छोड़ा। हमारा कॉलेज है तो वो पैरामेडिक्स के लोग जो हैं वो अपने लेवल पे अपनी कॉन्फ्रेंस करा रहे हैं और ये सारी कॉन्फ्रेंस जाके फिर रेस्कॉन पे जाके फाइनलाइज हो जाएगी। बस 2 मिनट और दीजिएगा। अपना सिर्फ इंडस्ट्रियल लिंकेज का मैंने आपको बता दिया कि इंडस्ट्रियल, ये हमारे यहाँ यूनिवर्सिटी में ETTP है, एंटरप्रेन्योरियल टीचिंग एंड ट्रेनिंग प्रोग्राम। हमारे यहाँ हम ट्रेडिशनल फिजियोज बना रहे हैं, हम ट्रेडिशनल SLPs प्रोड्यूस कर रहे हैं, हम ट्रेडिशनल ऑप्टोमेट्रिस्ट प्रोड्यूस कर रहे हैं। कोई ऐसा हो जो हेल्थ केयर सेक्टर में कोई इनोवेशन लेके आए, कोई ऐसा गैजेट क्रिएट किया जाए, ऑप्टोमेट्री वाले कर सकते हैं, इसी तरीके से MIT वाले कर सकते हैं। आगे आर्टिफिशियल इंटेलिजेंस का दौर आ रहा है, कोई एल्गोरिथम डिज़ाइनिंग होनी चाहिए, कोई ऐसे सॉफ्टवेयर्स होने चाहिए जिस पे आपकी असेसमेंट हो। हम हमेशा बाहर से टूल्स लेते हैं, उनको उर्दू में तर्जमा करते हैं, हम सारे मिलके क्यों नहीं बना सकते। तो लिहाजा हमने अपनी यूनिवर्सिटी में एंटरप्रेन्योरियल टीचिंग एंड ट्रेनिंग प्रोग्राम शुरू किया है। हम इंशाल्लाह अपने लोगों को, अपने स्टूडेंट्स को, स्पेशली अंडर ग्रेजुएट, पोस्ट ग्रेजुएट्स को ऐसा ट्रेन कर रहे हैं कि जो प्रोजेक्ट निकले जो कमर्शियली वायेबल हों, जो इंडस्ट्री में सोल्यूशन क्रिएट कर सकें। ये आर्टिफिशियल इंटेलिजेंस का मैंने आपको बता दिया। वे फॉरवर्ड क्या है, देखें, हमें अपने कोर्सेज को कंटेक्चुअलाइज करना चाहिए इंडस्ट्री के मुताबिक। मेरा यहाँ का आज का जो मैसेज है वो ये है कि हमने अपना कैरिकुलम SDGs के मुताबिक भी, UN सस्टेनेबल गोल्स हैं, हमने अपने सारे डिपार्टमेंट्स का जो करिकुलम है वो SDGs के मुताबिक कर दिया है। इवन आप जो रिसर्च प्रोड्यूस कर रहे हैं, अपनी रिसर्च को अपने आर्टिकल्स में रेलेवेंट SDGs को मेंशन करें, ताकि आपकी जो है साइटेशन ज़्यादा हो, आपका जो इम्पैक्ट है इंटरनेशनली वो ज़्यादा हो सके कि आप किस SDGs के साथ काम कर रहे हैं। डिस्क्लेमर में लिख दें या SDGs वहाँ पे आप मेंशन कर दें। तो लिहाजा बगैर इंडस्ट्री के कंटेक्चुअलाइज करें, और इंशाल्लाह वी हैव ए प्लान कि 2028 में सुपीरियर यूनिवर्सिटी विल बी द लीडिंग रिसर्च यूनिवर्सिटी, और उसमें रिहेबिलिटेशन और अलाइड हेल्थ साइंसेज जो है उसके कमर्शियल प्रोजेक्ट्स इफ़ वी लिव टुगेदर तो हम इंशाल्लाह आपको 2028 में इसके कमर्शलाइज प्रोजेक्ट्स भी दिखाएंगे। और आखिरी बात, दिस एन ईरा ऑफ कोलैबोरेशन एंड टुगेदरनेस। हम यहाँ इकट्ठे हुए हैं और ये जितने मेरे साथ बाकी मेरे कोलीग्स हैं, इसी तरीके से इंशाल्लाह वी वर्क टुगेदर, और हम ताकि रिहेबिलिटेशन और AHS के लोग बताएं बाकी डिसिप्लिन्स को कि वी आर द 60% ऑफ द टोटल मेडिसिन एंड सर्जरी। हमारे बगैर ना सर्जरी चल सकती है ना मेडिसिन चल सकती है, तो लिहाजा हम ऐसा कंट्रीब्यूट करें कि हम उनको दिखा सकें कि वी कैन डू समथिंग बेटर देन देम। थैंक यू वेरी मच।
Thank you so much, sir, for your address. Now, I would like to invite our worthy co-chair, Dr. Muhammad bin Afsar Jan, to summarize the session.
Thank you very much. It was a wonderful session, and I feel honored to be a co-chair of the first plenary session with such renowned speakers. I understand the challenge faced by the speakers to tune between their presentation and the audience, and especially it was a challenge for the co-chairs as well to understand what the speakers were and to keep the pace with the speakers as well. So the first speaker was Dr. Alia Al-Ghari, and she spoke about the sleep in athletes. It started off with the importance of sleep and its effects on body and mind, and she importantly connected it to the sleep disorders with physical therapy management of clients, especially the athletes, and the role of sleep in tissue healing, reversing the inflammatory changes that are related to trauma and overuse in athletes, and especially the decision-making process of which are critical to the athletes. And she further explained the outcome measures that we use to diagnose the sleep disorders and the important management strategies that physios has to adopt when dealing with the athletes. And in the end, she concluded with the message that there is increased incidence of sleep disorders in athletes, and there's a high impact on physical and cognitive function to the athletes as well. The second speaker was Dr. Shane Patman, and he spoke about the rehabilitation and allied health sciences, the challenges in practice and research, and started off with the clinical lessons and the public health issues and challenges faced by the world in the recent years in the era of pandemic. And he further explained the challenges faced by the workflow, the team management and the workforce planning related to the infection control, the staff availability, mobility and health, and tele-rehab. He further explained the challenges faced by the education, from the education perspective, the challenges faced by the students in education and the graduates for their CPD activities. He further explained the impact on the research conduct as well, and the challenges regarding the scientific knowledge, graduates and data collection and publishing, and the advocacy perspectives, a physical therapist role and the client demand. In the end, he explained about the post-COVID conditions and effect on everyday functions and the role of rehab specialist in management and to be safe and do not harm. The third speaker was Dr. Caroline Brown, and she spoke about the honing our information and research literacy skills in fake news era. And she started with the question why they wrote the book for the professionals and the parents and the reasons behind it. And she discussed the contrasting scientific and pseudoscientific interventions in science, the 7-point safety check against pseudoscience, factors to be considered for research little professionals, and tips for discussing vaccination. In the end, she emphasized to be unafraid to liven up things, create a disturbance, and raise issues that otherwise left dormant. The rest of the speakers would be discussed by the other co-chair. Thank you.
Thank you so much, sir. Now I would like to invite the next co-chair of this session, Professor Dr. Ashfaq Ahmed, to please summarize the session.
Bismillahirrahmanirrahim. First of all, I'm extremely thankful to Rifa International University for inviting me and also giving me an opportunity to co-chair the wonderful session. I would like to summarize Dr. Hayat Mustafa. Thank you so much for such a wonderful lecture on motor control, testing and retraining for managing lumbar spine, a kinetic control based movement solution. She has a background of teaching in Cairo University as well as in UK. The problem was low back pain. She highlighted components of kinetic control. She also emphasized that physical therapists should address kinesiopathological conditions. She highlighted dynamics, system theory, and muscles classification model. Then she also highlighted the big five. And in the end, the management was mainly focused with range improvement, translation, and nutshell was the exercise, which was the key factor to improve the lumbar spine pain. Our next speaker was Dr. Aisha Kamal Bhatt. She highlighted the breaking barriers, augmentative and alternative communication in Pakistan. She also highlighted different barriers and discussed the WHA GATE project, role of devices. She also mentioned that why the AAC model is not working due to the myths about ACC, lack of knowledge, attitude, non-availability of resources. She also presented an impactful research of 6-month case study in which she highlighted, trained the speech and language therapist. Then very known physical therapist Dr. Ilyas Sayyed, he came and highlighted the pioneering cost-effective physical rehabilitation in Pakistan, the Paraplegic Center Peshawar, which was the case study. He highlighted the modern medicine, components of modern medicine, components of rehab medicine, and widely discussed the concept of comprehensive physical rehab, including holistic approach, interdisciplinary, and all under one roof with the emphasis. He also highlighted the role of interdisciplinary team, including all health professionals, and of course highlighted the services and achievements of Peshawar Paraplegic Center. In the end, in the last but not the least, Professor Dr. Naveed Babar, who highlighted the future of rehabilitation and allied health sciences in Pakistan in promising outlook. He discussed the history of allied health sciences and rehab sciences and their entry in the Pakistan. He also took some time to discuss the variety and diversity of allied health sciences program in Pakistan. Then he highlighted the role of allied health sciences and their career opportunities, and highlighted the achievements of Superior University so far. So thank you very much for your presentation. Thank you.
Thank you so much, sir, for summarizing the session. Now I would like to invite our worthy chair, Dr. Mehbubur Rahman, to please conclude the session.
Assalamu alaikum everyone. I will not take too much because I think there is an appetite. Everyone wants to have something. But I'll just take 5 minutes just to brief about these people who was talked about. The first one was Alia. The Alia, I will say that if you want to go to sleep remember the Almighty Allah, then you will have a nice sleep. The second one was Petzman, Shame Petzman. He talked about the public health issues, and I will say that early intervention is more important for disasters and all these things. And I was lucky that in COVID, I published first paper on 27th April 2020, CPAP may be used as ventilator in COVID-19. It was published in Emergency and Critical Journal, UK. So the other were multidisciplinary talk was by Dr. Ilyas Naveed Pawar, talked about the future of this rehabilitation, and all was quite good and quite I appreciate. And with these remarks, I thank all you. I welcome once again the expected guests over here, and you have listened us all this with the patience, and thank you very much, all of you. Thank you.
Thank you, sir. I'm thankful to all the guest speakers and participants to this session. We'll have lunch and prayer break of half an hour. We'll back to the plenary session too after half an hour, inshallah. Thanks to everyone.